what I will do is go ahead and get started with some introductions while other people may join in. So all of you know me, so I don't feel the need to introduce myself much, but I do need to do what my employer expects and give you my disclaimers, which are I have no vested interests in what I'm about to tell you, other than that I wrote a book about this. So if you buy the book, I get a penny or two.
All right.
Yeah. And the other is that these are my opinions. They are not the opinions of the Department of Defense, the United States government, the Uniformed Services University of the Health Sciences, or the Henry M. Jackson Foundation for the Advancement of Military Medicine, who pay my salary. So
you've said this before. It comes out so naturally,
doesn't it? So, I have to submit everything to the government censors before I'm allowed to present it publicly, and that just bugs me, right?
All right.
So, yeah. Hello, Theodora. So my goal for when this hour is over is that you'll be able to describe 5 practices that sick kids use to sustain hope in the midst of chronic illness. And you'll be able to adopt a solution-focused stance toward amplifying hope among sick children. And that you'll be able to coach members of the treatment team in at least one solution-focused approach to amplifying hope with sick children. And we're going to do a lot of conversation with each other, more than just me talking. At least that's my intention. So we'll see if that works. I want to start with introductions by asking you all to introduce yourselves. And I'm going to put a couple of questions in the chat that I'd like you to consider when you introduce yourselves. So Gwen, you're at the top of my screen. Would you start?
Wait, are there questions we were supposed to consider in the chat first?
Oh, the 2 questions are: what parts of your identity are most salient for today's conversation, and what needs to happen in the next 60 minutes for it to be time well spent?
Oh, great. So my name is Gwen Loeb, she, her. I'm on the land of the Ohlone, and parts of my identity most salient for today's conversation is that I founded an organization called World Builders Incubator that is trying to shift the collective focus towards solutions. And a lot of that is hope as an action. So inspiring action versus the just sort of passive despair that we're all in. And the next 60 minutes hearing how this all applies to sick children, I feel that, and to care teams, I feel that for me, hearing that, I can apply that into the entertainment that we're creating, and also just learning communication skills and methods.
Great. Hey, Sun, how about you?
This is such a big question. Wow. I think right now, the part that I am bringing is, I'm from Toronto, by the way, is that just this afternoon, I got a call from my nephew's school. I had to go pick him up because he got into this fight, of course, out of all days today in the middle of the conference. And I had to go pick him up, and his lip damaged and all those things. And I think for me, what does that mean to stay hopeful in the state of maybe chronic crisis that a lot of children might perceive themselves to be in? So I think that's a question that I come up with today.
Great. Thank you. Gracie?
Hi. So I'm a marriage and family therapist in private practice in New York City. In my neighborhood where I live is the highest concentration of upper middle class parents with young children in the 5 boroughs. I'm only exaggerating a little bit. We have the best public school system in the city here, and I'm going someplace with this, which is I do an awful lot of couples work with parents of young children, and you get to witness some hard things. So that's what's salient about me. What will be helpful is hearing what you have to say about how to be with people with hard situations.
Thank you very much. Yishen, how about you?
Hey, thank you. I think the most important part of my identity is probably my role as a university educator in a healthcare professional context, and also as a training therapist. Learning how to build hope is always something that is interesting to me, and I think it's an important factor in all therapeutic relationships. So I think those two roles are most important. The second question is, what would be worth it? I would just have to say to be able to hear Duane's voice, is itself very, very great. But also perhaps if there are, practical things that I can think about on what to do, both as an educator and maybe as a clinician, how to help people, especially children, build hope, I would walk away feeling very good. But I do have to apologize that I can't stay for the entire session. So for prior engagement. So apologize
That's
for
all
that
right.
event.
That happens. Theodora, how about you? Thank you, Yishen.
Hi, it's nice to be here. I'm driving, so I'll be very quick. So the most salient identity, I suppose, would be that I am an older woman. I entered that phase recently. And I'd like to hear about how you live or how you work with people, not just children, but since you're talking about children with chronic conditions. I think that the conversation will be relevant to the work I do with patients who have chronic pain. So thanks very much. I'll be home soon and I'll be on video.
Great. Thank you very much. Drive safely. Kathy, you just joined us, but I am asking people to introduce themselves with the most salient part of their identity for today, and what needs to happen in the next 60 minutes for it to feel like time well spent.
Gosh.
I know
I
this
think
word.
just,
Yes, you just got here.
I surely did. Look, well, I've just been enjoying the conference overall, to be honest. And I think every single session I've been to, I've been able to glean something perhaps that I didn't quite have in my mind before. So I think if by the end of this session, there is just that little bit of a nugget somewhere, I'd be absolutely thrilled and delighted. So, and just being able to connect and see other people on screen is fabulous. So thank you.
Great. Thank you. And are you a therapist, a healthcare provider?
I'm a social worker by training. I've worked in the medical setting in tertiary hospitals, transplant units for 35 plus years. I've actually just transitioned to retirement, if you like, last year, and I'm not currently in the official workforce. So yeah, that's me.
Great.
But I've still got a very strong interest in the solution focused field and looking at where to from here.
Great. Thank you.
So
what I'm going to present to you is from this book that I released last month called After the Worst Day Ever, What Sick Kids Know About Sustaining Hope in Chronic Illness. And it is a grounded theory study of 51 kids with end-stage renal disease, most of them who spend time in a dialysis unit, a number of whom are part of transplant clinics, and we interviewed them using a solution-focused frame to try and understand how they perceive hope and what they say sustains hope, what the members of the interdisciplinary treatment team do, and what they do to keep hope alive in the midst of a chronic illness that is incurable, right? It can be treated, but even the treatments have pretty devastating side effects that keep you sick. And one of the reasons end-stage renal disease is important is that it's considered a paradigmatic chronic illness, meaning what people with kidney disease go through is what people with any kind of chronic condition go through, sometimes amplified. But the things that these kids say shed light for all of us who live with chronicity, which is about half of the US population at this point, and will probably be all of us at one time or another. One of the things these kids helped me understand is that we're all temporarily well. It's not a static condition, and it's not something you can reach, right? It's something you live into. So what I want to do is highlight the 5 practices that that children talk about, and then have some conversation together about the connections with solution-focused practice and solution-focused thinking. So feel free to interrupt if you have questions. This can be fairly informal, particularly since we're a small group, and I can talk forever. So feel free to interrupt me. Hazen, was that a hand? No. Okay.
There was a pop-up, so I'm trying to get rid of it so I can see the screen.
So the first practice, the most important practice for these kids, is what we have come to call realizing community. And that is the process of being socialized into what it means to be part of the interdisciplinary treatment team. These kids are not just patients. They are part of the team that is helping sustain themselves in the midst of illness. And they make a very important distinction between healthcare providers who treat them as objects or who talk to their parents, and healthcare providers who engage them as people and talk to them directly. And the community involves everyone involved in the treatment process, not only healthcare professionals, but also their parents, their extended family, and other kids in the dialysis unit. One of the things we learned is that these kids mentor each other, and that's a big part of what sustains hope for each other. They have peers who understand what they're going through, and they have healthcare providers who treat them like they're a part of the team, not like they're just there to get help. A second practice that these kids name is claiming power, and that has two dimensions. One is claiming power in relationship to their illness, not letting it define who they are, but being able to say, that's kidney disease, this is me, and here's the influence we have on each other. I am not defined by kidney disease, and it doesn't run my life. And the other is claiming power in relationship to the interdisciplinary treatment team, using their agency to make decisions about their health, using their agency to get information from the treatment team. And one big part of claiming power is these kids want to know the truth about their health condition. They don't want it sugar-coated. They don't want to know only the good news. They want to know everything so that they can make informed decisions about how to live with their illness. The third practice that kids talk about is what we have called attending to spirit. And this is kids who access the transpersonal dimensions of reality, of life, as resources to sustain them in the midst of suffering. A lot of them talk about God. Some of them talk about the ancestors. Others of them talk about symbols and material religion, wearing a necklace with a religious symbol on it, having cards or letters from classmates and congregations on their walls, reading sacred text, using different kinds of prayer. That was actually the third most important practice that these kids identified, which is significant because most of the hope research from psychological and sociological perspectives doesn't engage spirituality at all. Interesting. The fourth practice that these kids talk about is choosing trust. They know what's true and real about their condition. They understand that things might not turn out the way they want them to be, and they choose to trust anyway. They trust their health team. They trust themselves, they trust their families, and they trust in the goodness of life, that ultimately good things can happen even though they're sick. For them, being hopeful doesn't mean being cured. It means living well with illness. They understand that everybody is temporarily healthy, but that they can trust that process, that they're not so different from everybody else. And they invest a lot in the people and activities they choose to trust, and they let go of those that they don't perceive as trustworthy. And the fifth practice is what we have called maintaining identity. And this is keeping the parts of themselves that they knew before their diagnosis alive. So I am not a kid with kidney disease who happens to play soccer. I'm a soccer player who lives with kidney disease, right? In narrative therapy, we would call it externalization. But in particular, practices from the healthcare team that help them maintain those pre-disease identities are really, really important. So those, very quickly, are the 5 practices. One of the takeaways from this is that when adults talk about hope, they talk about hope in terms of the future, right? And we do that in solution-focused practice. What's your preferred future? What's your vision for the future? For these kids, hope is less of a future-oriented construct than a construct oriented toward the present. Yeah, they experience hope here and now in practices, not in something they hope will happen in the future. They also treat hope as a social resource. It's something that we learn with each other and then internalize. For them, it's not a feeling or a set of cognitive skills or a virtue that they practice. It's something that they get from the community and their relationships that they can then use to sustain themselves in the midst of illness. So I've gone over those very, very quickly. Let me pause and hear responses or questions or things you might want to say before we delve into some conversation. Nobody.
The last thing you said, Duane, sounded pretty Buddhist to me.
Yeah.
Say more. How so?
Well, it sounds like, well, people may not know this about me, especially if they don't know me. I've been studying Zen for a long time. I've been sitting and attending retreats, and it's a big part of what I do. I don't talk about it much. But certainly in Zen and other Buddhist traditions, life is constantly being created and recreated, and you, like with solution focus, which I find a lot of correlations with,
Thank
you find what there is right now and work with that and pay attention to reality. I'm sure you could articulate better what I picked up on, but I'm wondering how much that informs your thinking.
It does influence my thinking so much. There's actually a book on Buddhism called Hope, a Delusion. Buddhists,
I don't know that
don't,
one. I'll have to look at it.
Buddhists don't put much stock in hope.
Yeah,
they
exactly.
See it as a source of suffering. And I actually had a client who said to me once, "Don't make me be hopeful. I hate being hopeful." Right? So this emphasis on the present, when you ask kids to tell stories about the time they felt hope or the time that increased their hope, they talk about sitting around the dinner table with their family. They talk about playing video games with their kids. They talk about the time a doctor was honest with them. They don't talk about when something came true that they'd wished for, right? It's very interesting that it's so relational and so oriented toward the present, because in our culture, we think of hope as such a chronological concept. And for these kids, it is a relational and topological concept. When and where does hope come to alive? Not or with whom and where, not when, right? And so they look for that. Thank you, Gracie. How about others?
And I love that you say that, Duane, because I just remember being tortured by hope, being a caregiver to somebody who was going through chronic terminal, that we knew that end is coming, but then out of really good intention, so many people, friends, family, even like clinicians, they try to do something to enact this hope, and how we were so tortured. And I really resonate with that. Hope as social resource, as you say. And that, maybe one day it will be better, or that kind of things did not help at all.
No, because you're not going to get better, right? That's one thing these kids say. I mean, kids who are diagnosed with this disease have a shorter lifespan than kids their age. Even if they get a kidney transplant, a transplant lasts about 15 years, right? So they already have a truncated sense of the future. That, and for some kids, it's hard to imagine a future, right? If you can't imagine a future, you can't be hopeful. Well, that's not exactly true. So thank you, Hazel, very much. Anybody else?
Yeah, I just want to continue the observation that the the hope you're talking about is, again, not about a future state of affairs, right? It's very much focused on the living with, right? Or how do I have a good quality of life? And the words that come to mind are things like belonging, being able to feel at home with myself, even while I'm experiencing something very challenging and difficult. And I wonder about, the possibility of also reframing hope for the future as well, like, in the standard model where we tend to think about, Western professional context where we are all about achieving things or having a certain kind of outcome. And I think this could serve as potentially a critical reflection on maybe the things that we're used to going after, taught by our culture, is not really the most important thing.
Thank you. Yeah. Anybody else? Comments or questions?
I'm hearing the difference between hope and optimism, with hope being something concrete and action or community based, as opposed to just a blind chipper attitude, which feels like what is often sort of imposed on the chronically ill, is be optimistic and using hope as a, keep a positive mental attitude, you'll be just fine, buckaroo. So I mean, I'm curious if you were able to talk with the kids about how they define hope, like what hope meant to them, as opposed to just optimism. Like what does that word mean to them?
Yeah, first, Kathy, I noticed you unmuted, so I'm going to get to you. But,
that's okay. You can keep moving on if you want. I'll add later on. No problem.
When you ask kids what hope is, they say things like, hope is just something, it's there. It gives you energy to keep going. Kids don't talk in abstract concepts, so it gets much clearer when you ask them to share concrete stories about what hope is. And they will talk about it as a feeling, but it's a feeling, it doesn't start as a feeling. It's a feeling they recognize from having felt it before when hope has encountered. But they talk about it as something that gives them the energy to keep going. They talk about it as a way of knowing that they're loved. And they talk about it as hope gives me the ability to make a difference with other people. Is also a big part of it for them. That a number of these kids want to become kidney doctors or nurses or teachers. They want to give back to other people. And some hospitals capitalize on that because they help. They teach these kids to lobby for funding and that kind of thing, which is a way of giving back. So it's very action oriented. And the distinctions you named about action oriented, reality based, multiple outcomes are the ways that psychologists talk about what hope is in opposition to optimism. Now, optimism is not reality based. It's a general orientation that everything will turn out okay without being related to what's necessarily there, right? Whereas hope takes into account limitations and is able to identify multiple objects of hope. So thank you for that. Kathy.
Look, I think you just actually touched on what I had been thinking about. I've actually worked extensively with kids with end-stage kidney disease, predominantly sort of the teenage group upwards, but a lot of the children were children, they developed kidney disease as youngsters, and I may not have known them or had contact with them during that time. But I think this whole concept of hope with them was very much hope for sometimes just getting through the day, or hope for a good weekend, or hope for be able to eat that night when they've been nauseous all day. So I think it's very interesting when you look at the whole concept of hope and also relaying it to their families. There was a sense of burden on their families even at that young age, and hope for that they could just make things a bit easier all round. So I was just curious and then thinking about the spirituality side of it. And I think that is not very clearly articulated by the children, but it's tied in with the sense of this knowledge of this very deep-seated knowledge about where they're actually at and how far they're allowed to articulate their hopes and fears. So I'm just curious to hear further what you've got to say, but I've resonated very much with everything you've said so far.
Thank you. I'm relieved.
Please know you're doing good.
What we call choosing hope now, we originally called learning wisdom, because there was that sense that kids would talk about of, I know things that other kids don't because I've been sick. That I have a special insight into the world, and not in an ego building way, but I know something about life that other people don't. So that's still a part of choosing trust, which beyond the pilot study broadened, which is why we changed it from the wisdom to the trust piece. But they do have a sense of, I have special knowledge and gifts and obligations because of this. They also are painfully aware of being a burden on their families, particularly kids who are from undocumented families or from families of day laborers who don't have insurance. And one of the stories in the book is a kid who says, look, my hope is that I'll be able to graduate from college and get a job to pay for my medications. And someone commented, that's a whole commentary on our healthcare system, that's what this kid hopes for, is to pay for medications to keep himself alive. It's not only that, of course, but yes, you know these kids. Theodora, you turned on your camera, so I suspect that means you want to say something.
Well, just that I got home.
Oh, very good.
But the thing that a few things resonate with me. One is the idea of living well with illness, right? Living well with illness and the truncated life expectancy. So not just children, but people with cancer, right? People with Parkinson's, et cetera, in my caseload. And so the idea of living well with illness and what does that look like really resonates. Yeah. I appreciate the insight these little guys have. These youngsters have, right? That wisdom that they share.
There was an adolescent a woman who I was there the day she was diagnosed, and many months later I ran into her in the dialysis unit, and she asked me how my research was going, and I said something like, gosh, I'm learning so much from you guys. And she just said, yeah, we could teach you people a lot if you'd learn to listen to us. Right?
It's the truth.
It is true. It is true. Just because they can't articulate the way adults do doesn't mean they don't know things, right? That we either have forgotten or might not even know. So I want to welcome Caroline, who dropped in the midst of our conversation. So don't be afraid to jump in if you have something to say, Caroline. One of the things that's interesting is when these kids talk about what the interprofessional team does to sustain hope, most of the behaviors they talk about on the behalf of nurses and phlebotomists and physicians and other people are unintentional. They're things that the clinicians see as, oh, I'm just doing that because I'm here. They don't understand it as an intervention. Like saying, so you still like that boy you talked about last time you were here? What'd you do at the mall this weekend? Hey, did you watch the soccer game? Which all reinforce that identity beyond the disease, right? But the clinician doesn't see that as an intervention. Likewise, often the clinician doesn't see the teaching of the child about disease, which is a part of claiming power and realizing community, as an essential part of treatment. It is an addendum, an add-on, whereas the kids see that as the most important part of treatment. So it is interesting that we can teach clinicians and healthcare professionals to be more intentional about these practices that kids say nurture hope, because they're so simple that they often don't occur to us to ask questions about identity and agency and possibility and the transcendent dimensions of life. But kids will engage if we do ask those questions. So some of the things I wonder about that I hoped you all would help me think about is what options do you see for a solution-focused stance informing these kinds of practices that kids name? Or how do you see solution-focused thought and practice shaping the way you might use this information? Don't everybody talk at once, you know?
Well, you were really talking about noticing what works. And I don't know how it takes place in this context, but that was just such a profound example of just asking the kids regular life questions that works. So it's constantly noticing what works, noticing
and naming. Yeah, highlighting. Somebody else. Hey, son, you turned on your mic.
Yeah, I was just as you speak about this, my friend who has chronic illness. On top of that, she's a musician and she just lost her hearing. In her 1 year, just went swimming and just out of the water, and she couldn't hear anymore. And it's been a few months, and for her to talk about this disease, she actually pronounced it differently just a few days ago when we were talking, and she said dis-ease. And that's exactly how it's spelled. It's dis-ease. So then she was able to see this as inconvenience rather than something that identifies her. It's not like my label versus this is like, it's dis-ease. I'm not easy with this, but how do we live with it? And I think seeing her turn that corner gave me a lot of actually hope to witness that. Right. So I think I was just thinking about that it's just seeing it as dis-ease. Yeah.
Thanks. Eudora?
So I like that idea of these kiddos having some wisdom almost beyond their years, right? So I might wonder with them or anyone, like in this future place, what wisdom might you be sharing with someone else who is coming up behind you, or who you might meet? Like, is there yeah, that's what I would wonder. If they have some thoughts about that.
And why would you wonder that?
I like the idea that what that adolescent said to you. If y'all listen to us, we would tell you, right? And so they may have some things in their heart, right, that they haven't been able to put words to because for whatever reason. And so sort of making space for them to consider that, I think would be not only important, but very valuable. That's how I got there.
One of the interview questions was, if a new kid came in who's just been diagnosed and they were in the bed next to you for dialysis, what would you tell them about how to stay hopeful? Yeah, which is where some of these insights came from, right? Another is a story from the book. And I don't want to get stuck on telling the stories, but a kid who he got made fun of a lot at school, and his way of dealing with that was he and his cousin would trap someone on the elevator and beat them up to keep kids from making, like, it was a lesson. Somebody got beat up, and that proved that he wasn't that sick, and they would stop teasing him, right? And he was so anxious in dialysis that he yanked the tubing out of his arm. And they had him meet with a therapist to learn to manage his anxiety. And several months later, a new kid came in with his name, who was also very anxious in dialysis, and he asked the kid's parents if he could teach this new kid the techniques he'd learned with deep breathing to manage his anxiety. And he did that. And he, from that, took away something about, oh, it's helpful if I teach other people. So then when he started a new school with a transplant, and then the transplant failed, so he had to go back on dialysis, which meant he was coming to school late all the time and yada, yada, yada. And the teachers didn't believe he was a kidney keys kid. They thought he was skipping and some other things. So instead of beating somebody up, he thought, how can I teach these people about how I cope? And he asked the school principal to speak at a school assembly about kidney disease and what it was like to go to school with kidney disease and what he needed from the school. Yeah.
Beautiful.
And it was beautiful. And then the school district asked him to be on a committee to help advise how to work with other kids with chronic illness, right? So they have wisdom and they learn. And we can see that. Yes. Thank you, Theodore.
Yep. Thank you, Duane.
Yeah. Anybody else?
And I think it's for those exact reasons too that I'd often do that slight delving into the past, perhaps history of the outcome question. So I'd be very interested to support them to find the language which could have got lost in the here and the now and the busyness and just the practicalities of getting there and having to think, how am I going to handle, the kids at school, reminding them that it's okay to have a conversation with you about, and how did you do that? Or tell me about a time when A, B, and C was there, whatever their small hope might be. And so they can articulate very clearly. They might say, actually, when I was 6 or when I was 7, blah, 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 I was out hiking with my dad and this happened and that. And then it's like, wow, how did you do that? And what would your dad most have noticed? And then you might be able to then relate it to that next kid in the bed coming to dialysis for the first time. So I think it's joining the dots, but supporting them with language that's perhaps very suited to their juvenile status, but their status which is one of wisdom at the same time. And just finding the words, the language, whether it's using cards, whether it's whatever the technique might actually be, but supporting kids to know that they've got this in ways that they probably have never been able to articulate.
Yes. And what you're talking about fits so well with Haeson's dialogical orientation quadrant, right? That the resourceful past and the preferred future, rather than the troublesome past or the fearful, the hideous future. Yeah. That's not your word, Haeson. I'm sorry, I corrupted your theory, but
no,
yes,
absolutely. No, it's all tied in. Totally.
Sticking close to their language and helping them find the language to talk about their resources and what they want to have happen. Nice. That's nice. Anybody else?
Yeah, if I may, can you hear me okay?
Yes, we can. Are you in the car?
Yes, I am. Yeah. One thing that I wanted to also point out in the book that you didn't touch on it in the presentation, but something in the book is that initially when you had asked about hope and you were surprised that the kids were telling you their mundane life and you were wondering when are they going to start talking about hope, right? And then you realize they are talking about hope. It's just that the assumptions that we as adults have about hope is being challenged, right? And I find that sort of that reflection to me also confirms one of the insights of the solution-focused framework, namely that sometimes the problem and the strength are very much the problem and the strength are intertwined, right? That the greater the measure of the problem, sometimes the greater salience of the strength is as well. And so that then it's maybe not surprising from the solution perspective that hope comes from this place where they're trying to live with rather than trying to talk about a future outcome as well. Yeah.
Yeah. Thank you very much. Anybody else? Gwen?
In listening to this, one of the things that keeps coming up for me is it feels like, as much as this is something that's going on with children, I keep hearing the reflections in how much this would also apply to any disenfranchised group, especially elders, who we tend to discount, right? Any group where their participation in their care is discounted. Those who aren't first language speakers in the place where they are, those who are elderly. It's definitely having resonances for some of the treatment that's going on with my dad right now, who has pervasive brain cancer. And sometimes the treatment itself is so overwhelming that we have to remind him that he has other aspects of his self, right, than just this treatment, right? And that's, in the absence of that reminder or those questions, but I don't think we're asking questions enough, right? There's imposition of, hey, remember this, and so just this reminder to, regardless of the group, to be asking, not just reminding, right? To be listening. That's
And to ask generative questions that engage the genius in the room, that assume that person has resources and abilities and memories. They don't need to be told. It needs to be elicited. Yeah. Theodora, you are pointing. Were you going to say something? No, you're just agreeing.
Yes, I love what you say. The regenerative questions, regenerative, right? Like not open-ended, but something more nuanced than just open-ended, as opposed like, tell me about your future, right? But generative, using their language, their concepts, their images. That's what that was. Like, yeah, that was a little, snap or something. It was a wonderful thing. Sorry to be so distracting here.
No. We should always strive to ask questions we don't possibly know the answer to.
Yeah.
Questions that generate a new experience for the person we're talking to, because they also don't know the answer yet. They only find the answer in responding to the question. So if I find myself wanting to ask a leading question because I think I know the answer, I try to like stop off and say, no, what can I ask about that I can't possibly know? Because then I'm tapping their wisdom and their genius to co-construct something rather than impose something, right? And
way to put it.
Say that again.
It's a really good way to put it. Let me ask a question that I don't know the answer to.
Yes.
Right? Like possibly know. It could be a very simple, like, what's your preferred future, and sort of go from there. But having that intentionality around when you're crafting questions,
yes.
Right? To be sure that you're checking myself as I'm thinking about this, that it's not leading.
Yes.
Because we only have 45 minutes, for pity's sake. We got to get somewhere.
That's right. Well, but a single question can be an intervention, right?
Yeah.
So not all of us work in a healthcare context, but I'm going to ask this question anyway. Given what we've talked about today, how would you want to participate differently as a member of the interdisciplinary team? Or how would you want this learning to influence other team members if you were part of a interprofessional treatment team?
I think that ideally you would support the entire team to take a solution-focused approach to their work, irrespective of what professional stream that they're from. And I'm quite certain that would have quite a big impact on conversations with children and young people, their families, and one another.
Thanks. Nice. Yes,
small pipe dream, but it would be fantastic. Yeah.
It would be. Yeah.
Yeah. I would want to encourage. Oh, sorry.
Go ahead, Gwen.
I would want to encourage everyone's chart to include more than their medical information, or to include aspects of their self outside of their disease.
I guess, to build on that, actually, Sarah Healing and Jennifer Goring's work actually is actually a lot to do with those conversations that we have. And I think, how do we have those conversations so that there's a clinical biomedical information is what they call it. So yes, you sit down, collect biomedical information, very useful for diagnosis, yes. But then what about the other part of the person-centered information that's useful for not diagnosis, but dialogue? So that's the piece that I'm actually thinking about. And one example that comes to my mind is when I was working with interprofessional team, in a very heated situation when they made medical assistance in dying in Canada legal in 2016. They put me in charge of working with the professional team to come up with a conversational algorithm. And I was put in a room where physicians are calling each other murderers. How do you go to?
Oh no!
How do you go home and sleep at night knowing that you killed somebody? And it was so heated. And then I realized that I cannot teach them, but I can facilitate conversations in solution-focused way. And I did that 3 sessions. And then after that, I walked in the room and they are still not happy, but they're like, so we've been talking about what's been better. So I was like, there you go.
Bring on better.
Yeah, even in that heated sort of real conversations into professional teams, not working together, them experiencing this as an intervention for them, I think was so useful. Right. So I sometimes wonder, do we teach them or do we actually do it together? Yeah.
I think we certainly have the conversation, because something I really have noticed is that there is actually so much goodwill in the healthcare setting. There is so much almost desperation to get it right and to really be patient-centered and to be supportive. But those traditional ways of doing it are still there, which have their time and place. And of course, essential good treatment has to happen quite irrespective of everything else. But I think to be really comfortable in having a different style of conversation and starting that session, that consultation, regardless of your professional stance. And so what are your best hopes for us being together today? We've got a 15-minute session, or what's your best hope? Anything. And so how would you know instead, or what would you most be noticing? Or if you went home today and things were just that tiny bit different, what might be the very first thing mum notices? But I think even a doctor can have that conversation with the child, even though their focus is on their urea levels, or, what's their creatinine today, or, are they getting enough filtration? What are we doing about this, that, and the next thing? So they can still be mindful of their job, but they can frame it in such a way that actually I think would take a lot of pressure off themselves, because they are feeling under the pump. And it would make a huge difference. Because if it's made a difference to me as a social worker, I would imagine it would make a big difference right across the board. And if we're all on the same page, that's fantastic as well. Anyway, I'll stop there. Let you continue, because I love hearing what you've got to say.
No, I love what you're saying. So, did somebody else have something you wanted to add, Theodora?
I piggyback off of what Kathy's saying. It's the same kind of thing that's rattling around in my brain, is that the idea of talking to patients. I'm in a psych outpatient department. So the question I would hope for the psychiatrists and NPs to ask in their 15 minutes is a question that is beyond the diagnosis, right?
Yes.
Well, tell me something beyond the diagnosis. We know that trauma, PD, all the diagnoses we have are part of what happens for you, but what else happens, right? And how will that look when this stuff is better, right? That, right, just beyond.
Absolutely. Yeah, and because they're so entwined.
Right. And I agree. I think that they all work very hard to do better for their patients, right? No one wants to see another person have another psychotic break or another episode of depression, right? Like, we get involved. We like and really care for our patients. And so I appreciate the comments you've made, Kathy, and this whole conversation. Thanks.
Yeah, I have in my setting pushed, people talk about patient-centered medicine, and I keep saying, forget patient-centered medicine. I don't want you to be patient-centered. I want you to be relationship-centered. Because if you take care of the relationship, then you're being patient-centered in a way that's not transactional or neoliberal or about improving, compliance or reducing lawsuits or those kinds of things. If you attend to your relationship with the patient, you will be patient-focused, and it will help you feel less urgent and less like a cog in the machine as a clinician.
Yeah.
You focus on the relationship. Yeah. Yes.
Just another quick thing to add to that way
Yes.
is that Kristen Bodyford, and she does the work with like organized healthcare organizations on loving organization, right? And then that was like, I was really blown away that, what do you mean by loving organization in healthcare? And question was very simple. It's like, suppose love organizes how you work. What would you keep? What would you change? And suppose love just organizes your workplace. And it was just such an insightful conversation. What would that look like if that's what we do? And so, I mean, I'm reminded of that work because this is what you do. It's not about patient-centered, but it's really just a human-centered. How to do this human-centered way? Yeah.
Yeah. I went in, so part of my job is to oversee a project between the university and the VA. The VA is the Veterans Health Administration in the U.S. And to create a leadership curriculum for their senior educational executives. And when in my first meeting with the VA, they told me all of the things they wanted to correct and all of the things that were wrong. I stopped the conversation and I said, oh yeah, I don't care about that stuff. Tell me what you'll notice about somebody a year after they're done with this program that will tell you we really hit the mark. And immediately they said, well, they'll be effective and empowered and confident. And it was amazing to watch the room change, but it's also been amazing to watch the VA own those things. This is what we want. They're no longer focused on what they don't want. They're focused on what they're trying to get to. And they talk about my magic conversation, and I keep saying it wasn't a magic conversation at all. I just redirected you. I asked you a question you hadn't thought of. Yeah.
And that is the total core essence. What do you want instead of what you're describing right now? And they started to articulate, and one thing leads to another, the differences, the noticing, and all of a sudden they were happy and excited because it was somewhere in their realm of possibility, perhaps. If it was in their imagination, perhaps it was getting a bit closer to 2% real.
Yes.
I do need to leave to go to the main room to get ready for the next closing, but thank you so much.
Lovely to see you, Hassan. Take care.
See you in the big room.
Yes. Bye, Hassan.
Bye. So I won't keep us much longer other than to express my gratitude for you all being here and the way you've engaged and the things I've learned from you. This research, of course, all research is me search, that kind of thing. That we only research the things that are salient to us, and it certainly has changed me. And I feel a responsibility to help people hear these voices. It's not that these kids are voiceless, it's that people don't listen. And so that's my hope for this work and for the book. And